We start, sir? Should we start?
Yes, ma'am. We should start now.
It is 6 o'clock, so has our speaker joined?
Yes, ma'am.
So, a very, very warm welcome to all our dear friends from public health who have joined us from 13 different countries of the world in different time zones. And yet, what brings us together is our love for public health, our love for the well being of public health. I'm very happy that we have successfully completed one round and we are into the second day of our 5-day workshop on research methods in public health. And it is my proud privilege to introduce the speaker for this morning, for this evening, Dr. Abyot Asres Sheton, who would be speaking to us on epidemiological study designs. A very, very warm welcome to you, sir, and thank you so much for agreeing to talk to all of us. And, I'm sure all of us will hugely benefit from the inputs that you are going to give us in terms of how cohort studies and other kinds of study designs can be undertaken. So let me at the outset, on behalf of Purnima University, on behalf of MMF, and on behalf of all the participants, welcome you. I accord a special welcome to you, sir. He is the Office of the Vice President for Research and Community Services at Mizan-Tepi University, Ethiopia. He has a PhD in public health and works as assistant professor of public health. He has authored and co-authored over 15 articles in reputed journals. He has worked as academic vice president, college dean, researcher, clinician, health facility and zonal health department leader. And these add up to 16 years of his service and development. He has taken on job trainings on different health and educational programs on TB, on HIV AIDS, on immunization, family health, health management information system, effective teaching skill, and advanced research methods. He has consulted, conducted different consultancies on various things within the framework of maternal health and national in-service training framework. He has received many awards and recognitions. He has received an award and recognition from the Federal Democratic Republic of Ethiopia, Ministry of Health, and Ethiopian Public Health Association for his outstanding contribution for the 13th World Congress on Public Health held in Addis Ababa in Ethiopia. Hawassa, Wellong, and Jimma universities also have accorded recognition to him for being an external examiner for students' master thesis. He, of course, holds a PhD and he has a number of, attended a number of trainings, but more especially, he he has been working for, since 2005. And so from the beginning, he has reached to the office of Vice President for Research and Community Service. He has authored about 15 original articles, 3 projects are underway. 7 students have taken their PhD under him, and he has carried out many consultancies that he has carried out in various paths. And of course, his skills and special abilities are that he can handle computers and all other things. We are so privileged, sir, to have such a person to talk to us today on epidemiological study design. And he would be talking about cohort study, case control study, observation study, retrospective study, prospective study, longitudinal study, and what have you. So he has a long list that he's going to cover in the next 2 hours that he's with us. A very, very warm welcome once again. And I request you to please address the gathering of people from around the world. Thank you for accepting to come. Welcome, Dr. Abyot. You are muted, sir. You are muted, sir. Welcome, sir.
Welcome, welcome. I'm audible, please. Hello.
Yes, you are, sir. Yes, you are audible.
Okay. Thank you very much. So on behalf of so how about the slides is being shared?
Yes, sir. Yes, sir.
Is the slide visible?
Yes, sir.
Okay, thank you very much. So I would like to take this opportunity also to thank the organizers, including university and also this the MTTF and also particular motivated staffs in our university. So as a Vice President for Research and Community Service, on behalf of the university, I would like to thank all these organizers and also all the participants at large. So I think my introduction about myself has been already addressed, and I don't want to take some minutes for discovering my previous careers and also for my future career. So I will just leading to the sessions that I'm going to deal with. So is it okay? Will I proceed to that?
Yes, sir. Please go ahead.
Okay, thank you very much. So I will be talking on epidemiological study designs. So with this, I will be addressing some of the concepts of public health and what public health is, and also the core functions of public health and what the fundamental assumptions behind the different design and the applications of epidemiology. And then also I'll be talking on the basic classifications, the features and some of the strengths and limitation of the epidemiological study designs, most commonly applied in different beat and observational and also experimental studies. And finally, I will have a talk on some of the major evaluation techniques of epidemiological evidence and particular about the treats. So I hope almost all the participants might have some awareness about the public health and also epidemiology. So I will be talking about some of the major things. So I'm going to talk about the details of all the disciplines. So public health, it's by the definition which was coined by Winslow. So it is an art and the science of preventing disease, prolonging life, which is by promoting different activities and then improving the quality of life, eliminating health inequalities and organizing the community to promote active participation. So it's all about the public health, it's all about the community health, it's all about the art and science applied in preventing, promoting, and rehabilitating all the health cares of the community. So as a public health, it's entirely dealt with the community, which is unlike that of the clinical medicine, which deals only with the individual patient. So as it has been said that in the different countries, it has been said that healthcare can be vital for all of them, all of us, but it can be for some time. But public health is vital. It's to all of us all the time. That's why we are dealing with the public health, because be it for the healthy, the seemingly healthy individual, the patient, all must require about the public health aspect. But all the clinical medicine can be, the healthcare can be applied only for those patients who are with a different illness and different sickness. So there are different approaches in clinical medicine and that of community medicine, and to reach at the problem at the patient, we might look into the history of individuals. It's about the physical findings, and about where we can also involve different types of tests, so that at the end we can reach at the diagnosis of an individual disease diagnosis, be it a typhoid fever, pneumonia, tuberculosis, whatever. But unlike analogous with that of this clinical medicine, we do have also different established methods and standard procedures that we need to look into that to come up with the problem of the community, which is the main essence of this public health and the main essence of epidemiology as in particular. So to come up with the problem of the community or to diagnose a community problem, first we need to talk with the community. It's about their problems, it's about their concerns, it's about their different issues within the community can be talked with the community. Then we can also review different records, be it research articles, it can be different reports, and also we can also conduct the primary survey. So with all this, we can reach out the problem of the community. That means the communal problem, the problems that can prevail in a given community. So these are both for the clinical medicine and that of the community medicine. So we do have established methods about history taking. There are established methods in the record reviewing. These are established methods in conducting surveys. All these can reach out at the diagnosis of the community and the problems of the community. So as a public health, as a discipline, so the public health has so many activities, but these are the three core functions. As a public health professional should play these core functions. The first thing is about assessment. So by assessment, we mean it's about assessing the needs of simply conducting surveillance and specific studies to reach out the community problem. So assessment is one of the core functions of public health. So one of the core functions of public health is assessment, which is entirely related with there is a discipline, with this epidemiological discipline. It's not only assessment, then after assessment, then also there's also a subsection for leadership. So with the leadership, after assessing the needs, and we need to design a program for intervention, we need to mobilize the resource, and also we need to mobilize the society for the betterment of the effectiveness of the intervention. So the leadership is also one of the core functions of a public health or one of the public health professionals. And the other thing is also provision of service. So this service could be a comprehensive, curative, it could be comprehensive, promotive, and preventive services also. So these can constitute the core functions of public health. So these are the core functions that can constitute the public health professionals, at the professional, also at the graduates. All individuals who are pursuing their public health or degrees must have these critical competencies in assessing, leadership, and provision of different public health services. So let's go to as a field of epidemiology. So epidemiology is also one of the basic science of public
Excuse me,
health.
doctor.
So, hello?
Please make full size of your PPT.
Okay, sorry. Is that full screen?
Yeah, it's fine. Fine now.
Okay. So epidemiology is a field of study which is concerned with particular assessment of the public health. As a core function of public health assessment can be dealt with this epidemiology. So it is as a field of study concerned with study and the determination of frequency, distribution, determinants of disease in human population. So there might be some epidemiological studies in different population, but the epidemiology entirely focused on the study of this frequency, distribution determinant, and determinants of disease in human population, and application of this evidence to the prevention control of the problems within the community. So this as a field of study, the main definition of epidemiology. So these are the key terms in the definitions are the frequency is about the different epidemiological events, and the most epidemiological events that we can encounter, it can be occurrence of disease, it can be occurrence of death, it can be occurrence of disability. So this can be quantified by making use of the different study designs we can measure about the frequency. With distribution, we can also distribute about the occurrence of certain health and health-related problems in the community by the different attributes like the personal attributes, the place attributes, and also time attributes. It's about the description of the occurring different types of health problems in a given community. It's about determinants, it's about risk factors. What are the factors that can determine the occurrence of disease, and what are the factors that can determine the occurrence of death and occurrence of disability can also be one of the main concerns of epidemiology. So as a field of study, epidemiology is entirely focusing on this, and it's not only about describing and coming up with this evidence, but the application of this evidence is the prevention and control of disease and health problems in a given community. So to do this, epidemiology works under these two basic assumptions. So the first thing, human diseases do not occur at random. So that is, if diseases do not occur at random, there are some factors that can contribute for the occurrence of disease, or there are some factors that can prevent individuals to get protected for a certain disease. So this is the main fundamental assumption behind the different designs for epidemiological studies. And the next thing, the human disease do have, the epidemiology also assumes that human disease do have its causal and also preventive factors. And it also assumes that these factors can be systematically investigated. That's why we need to look into the designs in which we can find out these different types of factors. So these are the basic assumptions behind the conduct of different study designs. So it works under these two basic assumptions. So as a field of studies, epidemiology can be the main objectives, or that can be attained by studying, conducting different types of epidemiological study designs. Is the first thing is about determination of extent of disease in a community. It's about the magnitude of the problem. It's about incidence. It's about the prevalence of certain problems in a given community. We can also investigate the etiology and the mode of transmission of disease. And we can also construct a natural history of disease, about the natural occurrence of a disease, and about the different subclinical, clinical occurrence, and also different types of the post-clinical recovery phases. And we can also establish this natural history with epidemiological studies. So we can also, the other objective of the epidemiological study is to estimate the risk of developing a disease. So we do have different factors. So we can compute the risk of, we can also quantify the risk of acquiring a certain disease, and we can also develop the base for prevention program based on the different types of risk we can compute. And we can also evaluate the new preventive and therapeutic measures. This can be about different vaccine trials, it can be different drug trials. So the different types mode of healthcare delivery that can be prevented, and that can be also evaluated for whether they're working based or not. So the effectiveness can be evaluated by, one of the objectives of this epidemiology is also about evaluating these different innovations and different types of therapeutic and therapeutic preventive innovations. And also, this also provides a foundation for developing public policy in different countries, and with the different types of regulatory decisions and different types of policy actions, and the strategies can be developed based on the evidence. So these are the main objectives of epidemiological. So with the different types of epidemiological studies, so we can attain these objectives. So at the end of the design, so every studies can lead to attainment of these different objectives. So the strategy with which these objectives can be attained is by conducting, it can be epidemiological surveillance, or it can be epidemiological research. And our today's concern and our today's topic and talk on about epidemiological research, but epidemiological surveillance is also one of the strategies with which we can answer and we can attain the objectives which is required of this epidemiological study. So by surveillance means about ongoing monitoring of different health events, so that we can monitor the different occurrences. We can also design different interventions, but the epidemiological research can also be conducted to obtain the objectives that I have displayed earlier. So by epidemiological study designs, we mean it is the design. It's a plan for, particularly the main definition for epidemiological design is about how the study subject is going to be selected, and then how the data is going to be obtained from different study subjects. So overall study design is about, it's a guide, it's a plan, it's a protocol that can guide us to how to select the study subject, and also how to obtain a data, and what type of data to obtain, and how to obtain the data on different types of study subjects. And in epidemiology, so this epidemiology is the main focus of epidemiology, particularly the human epidemiology or clinical epidemiology, whatever epidemiology, can be focusing on human beings. So, but most typically in the epidemiological studies, population can constitute, it can be an individual, so it can be some group of individuals, it can be in a household, it can be a community members, it can be a different structures within the government structure, it can be different countries. So we can also use the places as a population, and we can also use the time periods, particularly if we are using these time series studies. So the times can constitute a population, so that we can ultimately infer to these the different time periods. And sometimes even you can use the published studies can constitute a population, and these can typically work on when we are conducting meta-analysis and systematic review. So in this case, the population for which we are going to infer is about the published studies. So these are the populations that are most commonly focused with. The main focus of epidemiological studies focus about this population. So the study design is all about how to select the population, how to select this population, and then how to obtain the data, and also how to analyze the data. The overall guiding coordinated plan constitutes about epidemiological study design. So is this epidemiological study design direct how the investigation is going to be conducted, how the study is going to be conducted? That is to mean that how the subjects are going to be selected, who is going to be stated, and then how they are going to be stated, and what's going to be measured, and what variables are the key variables that can constitute for this study design. So with this epidemiological study design, we can also identify the different hypotheses that can be going to be tested, and we can also formally test with the different types of study designs. There is a plan about generating hypotheses, and they can also plan for formally testing hypotheses are generated by different types of descriptions. So as a source of information, so the information gathered for testing hypotheses, for generating hypotheses, and for answering different type of epidemiological questions can be primarily collected as the primary surveys, or we can also get the data from existing sources, including the routine healthcare facility routine reports, and we can also use a different national international report, and even we can also use a different published articles so that we can get this information to answer the different types of questions that can be raised for epidemiological study designs. And the most common ways with which we get the data by observation, interviewing, discussion, questionnaires, so physical examination, and different types of tests, be it a physiological, biochemical test. I hope our yesterday session was all about the data collection and about the methods of collection, the tools with which we are going to use the data, and then about validation. I think we have dealt all about the data collection, but the focus of for today is to note about the data collection. So to classify this, there are a number of study designs exist in epidemiology, but we need to classify them in terms of there are some standard designs that can account for most common epidemiological study researches. But we might have infinite number of study designs exist, but the standard designs can be very few in number, and these designs can be very much flexible, and sometimes this can also be efficient enough to address a wide range of questions in which can exist in public health and also in a different in epidemiological fields, so that the knowledge and the different knowledge and evidences on their pros and cons and about the advantage and disadvantage of specific designs is very much relevant to guide the selection of state designs. So because for certain question we might have a different design, so but based on the knowledge of these different pros and cons and advantage, disadvantage, limitations, so that we can opt for the different types of design that can be guided by our knowledge of these pros and cons of the specific state design. So broadly, epidemiological study designs can be classified into experimental and non-experimental. By non-experimental, we mean some are most commonly called observational studies. And these observational studies can further be classified into, sometimes the study can be analytic, and then the other categories, a broad category can be of descriptive series. So the different types of study designs can also consist. We are going to see about the specific study designs, and the most common analytical study, observational studies are the cohort studies, the case control studies, the cross-sectional studies that can consist on analytical studies. And with these descriptive studies, we can also use the cross-sectional surveys, case series, case report, and sometimes when we can use interchangeably with correlation and ecological studies posed as a descriptive and analytical study. So these constitute about observational studies, and we call it non-experimental. But the other category of the ecological study designs could be experimental, where we are going to intervene the exposure level of individuals that constitute about clinical trial, community trial, and other experimental designs. And I hope I don't know with tomorrow or the day after tomorrow, we will have a session for clinical trial that we will have a detailed description, detailed talk about the clinical trial, but today's session will be on primarily focusing on observational studies. So the classification can be based on the different time period or temporal relationship between the measurement and also the outcome of different disease. And for instance, for the descriptive studies, both the key variables in epidemiology what we commonly deal is exposure and outcome. And if all this exposure and outcome is going to be described as the same at one point in time, so this is about the descriptive series. So we don't have any temporal relationship between the exposure and that of the outcome variables. But if you start from individuals who are exposed to certain variables, and then we look forward to look into the outcome of the exposure variable, so these type of studies can constitute what we call a cohort study. And if you can also start from individuals who have outcome of interest, and then we look back into the exposure variables, so this type of designs can also be case control study. So this is also one of the way with which you can classify the study designs based on the temporal relationship between the data acquisition and that of the outcome occurrence and that of exposure occurrence. So based on the aim of the study, the study can also be classified in terms of aim. It can be descriptive and it can be analytic. So descriptive, we simply describe the occurrence of exposure and outcome. And with this, we ultimately generate hypothesis that's going to be tested with analytical studies. So the main aim of this descriptive study is about describing the occurrence, about describing the frequency, describing about the distribution. All this can be answered by the descriptive studies. And the most common descriptive studies that I have mentioned before is about this case report, case series, and cross-sectional studies, and even ecological studies can also constitute these descriptive studies. In the analytical studies, so the first descriptive studies answer about the main contents of the definition of epidemiology about frequency and distribution is going to be answered by having a descriptive study. So with descriptive study, we can answer about frequency, so we can answer about distribution. So after answering all this frequency and distribution, then ultimately we generate hypotheses that are going to be tested with analytical studies. So with analytical studies, this is about telling about determinant, which is one of the key components of the definition of epidemiology, is about identifying the determinant factors of different health and health-related events. So with analytical studies, we can test an hypothesis, and we can also measure association between exposure and outcome variables, so that we can test hypothesis whether that is casually linked or not. We can also associate about whether a factor is a risk factor, whether the factor is a protective factor can be identified with analytical studies. So the main difference between these descriptive and analytical studies is descriptive is a simple description of the occurrence, and we cannot test hypothesis, but we can test hypothesis with analytical studies. So we can identify the determinant factors, which is one of the key components of the definition of epidemiology. So with these two, both descriptive and analytical studies, we can handle all the concepts that we dealt in epidemiology about distribution, about frequency, about determinant, and about even the application of the evidence for prevention control of the disease and health-related problems. And the other, based on the time frame of the study, designs can also be at cross-sectional, can also be longitudinal. So by cross-sectional, we mean the study is conducted at one specified period of point in time. So in this case, this type of study is what we call the cross-sectional study. Sometimes can be quantitative surveys, can be qualitative surveys. Those constitute about the cross-sectional. That means the data is collected the investigation is carried out at one point in time. But sometimes, it's not sometimes, most of the time in healthcare practices, we usually do the longitudinal measurement. That measurement conducted at different point in time. So in that case, this type of designs are what constitutes what called a longitudinal study. So this longitudinal study can be constituted by, sometimes we can repeat the cross-sectional study at different point in time. So repeated cross-sectional studies can also constitute a longitudinal studies, and even we can also handle some prospective and retrospective follow-up studies that can also constitute longitudinal. So the main difference between the two is the measurement for the variables can be at different point in time, for a different point in time in the case of longitudinal, but in the case of cross-sectional, we usually measure all the variables and all the investigation can be done at one point in time. So if you look into this table, so for instance, the cross-sectional study can be conducted in 1 year, that is in one specified year, but the longitudinal, the course can be for about 10 or 5 years. So this the measurements can be carried out at different point in time. So that can constitute a longitudinal study. So we can follow them. We can also handle the different measurement at different point in time. I think this is the main essence of cross-sectional study. So the investigation is done at one point in time, at the cross-section of the population. But the prospective studies, so as this name indicates, this is looking forward. So we can measure something at the baseline, then we can look forward for observing the different outcomes. So this type of studies are what called prospective studies. So this can also constitute about the longitudinal measurement, about measuring for a long period of time at different point in time. And the follow-up can also be both prospective and retrospective. In the case of prospective, so we measure the baseline measurement and then we follow them forward. But in the case of retrospective study, this can also constitute a longitudinal study. But in this case, both outcomes and exposure might have occurred, but we can measure the baseline exposure and then we can also look forward, but backward to see for the outcome has been occurred or not. So this can, both the prospective and retrospective can also constitute about the longitudinal measurement. The measurement can.
Doctor, please excuse me. There is a pop information icon on your PowerPoint at the bottom. Please, if possible, hide it.
Okay. Which one?
At the bottom, we are seeing here. Yeah,
Okay.
It's fine now. Fine.
Okay. Thank you very much. Okay. So these are also different categories of longitudinal studies. So it can be prospective, it can be retrospective. So the longitude can be, we can establish a longitudinal measurement for routine management or routine data management. And then we can also prospectively measure different types of health events across time. So if you look into the different spacing state designs, so I think we have talked about this descriptive series, about the main essence of this descriptive series about describing the event within at one point in time. So we can measure, we can characterize a new disease, and we can also event a new disease with description. For instance, the most typical cases, for instance, about AIDS, definition of AIDS, even for the recent ones about the COVID, it's based on this description of a disease. So based on the description, so we can acquire a new disease. We can also invent a new disease. We can also invent a new occurrence, a new happening, and different health populations. So this can be used to determine the frequency of disease that can vary across different population groups, that can vary across different places, and also that can vary across different time spans. And with this, with the descriptive series, we undertake without any specific hypothesis about the cause and effect relationship. So we don't have any hypothesis being tested in the descriptive series. So if you are not going to test hypothesis, so we don't have any comparative group. So we are not going to compare different group of individuals so that we are not going to test hypothesis. Rather, we generate hypothesis. So we can generate from description, from different types of description, and from different types of quantity of disease or frequency of disease. So we can attribute certain illness to certain price. So we can also attribute certain illness to certain age group. So with this we can generate hypothesis that can be tested with different analytical study design. So the most common types of descriptive studies constitute about case report, which we commonly use in our clinical medicine. It's about reporting individual cases, about individual histories and individual physical findings and individual diagnosis. And we can also have a series of cases with similar findings. So we can also a case series and cross-sectional surveys, with which we can have representative studies. So we can have the population surveys, and we can have the population level measurement for different types of health outcomes. And we can also use ecological series to have these are the most common types of descriptive series which are commonly employed in epidemiological series. So as a case report, I think any clinical clinicians can have better awareness about case reports. So by case report, we will have a detailed description of a single case. About detailed description can constitute about the symptoms, the signs that individuals can manifest, and also the different physical findings, the different types of imaging results, right? Be it lab results and the different types of imaging results. So this can constitute about the detailed description of all the individual cases constituted what called the case report. So this can also constitute, this can be very helpful in describing a disease and the different types of previous or unknown disease. So it's also most important also to have an expected link between disease can also be observed with this case report. So with a detailed description of case, so we can invent a new disease, or we can also invent a new adverse effect for instance, for a therapy, for a given different types of drug. It can be for different types of vaccine. So with a detailed description of a case and detailed description of a different individual victim, so we can come up with a new event, a new unexpected event, even with a new occurrence of a disease in a given community. So these are the most common typical examples are these Alzheimer's disease, AIDS, COVID-19. Most diseases can be developed and discovered by this case report, by individual case report. And so most commonly, this generally reported as a simple clinical narrative. So we don't have any other structure, but as a clinical narrative containing all these components can constitute a case report. So as a case series, if the report can constitute more than one case, so if you have a series of cases having a similar features, so that detailed description of all these series of cases having a similar feature, that can constitute about the case series. So all these constitute about description of the cases. It can be for a single case, we call it a case report. And if there are a series of cases having a similar features, so we call it this type of designs what called a case series. So these are also a type of say design. So we can publish it. There are a number of publications with a case report. We have a number of publications with a case series. That can be very fundamental for different hypotheses and also fundamental for acquiring of a new disease and even invention of a new disease. So the main advantage of this type of these are case series and case reports about for hypothesis generation. So we can generate hypothesis. So we can inform for very rare disease with a few established risk factors. We can have a better informative description for a rare disease with a case series, and we can also characterize about average for disorder, particularly for case series. So we can have we can compute an average for disorders about average age. It can be average different times of occurrence can be computed with the case series, and it's very useful for epidemic investigation if you are encountering a series of cases with a similar features. So that can be a very prone to have epidemic. So that can be an indicator for development of epidemic, and it's very useful for useful for indicating whether that occurrence is going to be epidemic or not, and even in the be it a cluster, it can be in the form of outbreaks. And this is also very much useful for establishing natural history of disease with a detailed description. So we can describe the natural history of a different phenomenon in the human individuals, so the disease. So we can describe with a detailed description. It's very helpful for describing the natural history of a different alignments in a given individual. So the main limitation of this type of study designs is this cannot show any cause and effect relationship because we didn't test about hypothesis. It's a simple description. So with this simple description, we can't answer about whether a factor which is occurring in a given individual cannot be a factor for obtaining the outcome of interest and cannot assess the disease frequency and rate. So because we are dealing with as individuals, so we can deal with a very few individuals with a cluster of cases. So with this cluster of cases, it's very difficult to come up with the population level frequency and rate of occurrence of a disease. So the other studies is correlational studies, and these are or also called ecological studies. So this can also be considered as both analytical and also descriptive studies. So with ecological studies, the main interest of these ecological studies is about we are dealing with the entire population. It's not about individuals, unlike that of the case report or case series. So we are dealing with the data from entire population. We are dealing with an average in aggregate data. It's about the data about the whole population. For instance, about average income, the GDP of a given country, for instance, about the different maternal mortality ratio of a given country, or the GNI, and all this, the population density. This can consist about entire data on entire population. If you are dealing with this entire population level data, so we call this type of data is about ecological studies, because the main interest is about the ecology, is about the aggregate data, it's not about individual data. So as this data can be very inexpensively acquired, so it's very much quickly, it's also inexpensive. So we don't going to incur about the different money to get the data, because we can get an average from the different institutions, so that we can establish that we can come up with a say findings with a very few costs. So it's not costly, and it's also very quickly. So the main rationale behind for the conduct of these ecological studies is because sometimes it's very difficult to have the individual level data. For instance, about population density, for instance, about exposure to certain types of environmental exposure, that can be very difficult to measure at individual level. So in that case, it's very difficult to use individual level data, so that we can going to use an aggregate data. That the data that we can get for the whole population or for group of population that can constitute the data. We are going to use about aggregate data instead of this individual level data. So that's the main rationale is about sometimes the data at individual level cannot be available, so that we can use the data to use this ecological level data. So it's very much quick and very cheap. So if you find the evidence is timely to come up with a timely evidence, so and we don't have any resource limitation, so we can use this ecological studies. And variation exposure in at individual level is very much small. In this case, ecological studies can be very much useful, because if the variation at individual levels is very much minimal and very insignificant, in that case, ecological studies is more advisable to do it with unlike that of the cross-sectional studies that can use individual the representative samples. And ecological effect might be most important than the biological one. Sometimes the ecological effect, for instance, the effect of the aggregate level can be more important compared to that of individual biological level. So if these reasons prevail, so the most important design that we need to use is ecological studies, and we commonly call it the correlational study. These are the most common types of ecological studies. For instance, if you compare the coronary heart disease incidence with that of coffee consumption, so we can get the prevalence or base incidence of coronary heart disease in a given community from the different reports from the different national health authorities, and then so we can also have the coffee consumption from different types of expenditures on coffee. We can also come up with the import export of this coffee based on these aggregate figures. So we can correlate whether the coronary heart disease is associated with that of the coffee consumption or not. So in this case, we can have internal comparison between country to country. Even we can compare between locality to locality, so we can use an aggregate figure about an average figure for the whole population. We are not dealing with the individual level data. So for instance, stroke mortality in a given country can be compared with that of the vitamin C intake. So this intake can be measured in terms of the import of vitamin C, even the expenditure for vitamin C, even for the prescription of vitamin C. We can get about an average vitamin C prescribed from the hospitals. So we can also get about the vitamin C imported to a given country based on these aggregated figures and aggregated evidences. So we can relate whether stroke mortality and that of vitamins intake are correlated or not. So these are the typical examples of the correlational studies that using an aggregate data to that of the to that aggregate data to that of the individual, not individual, but aggregate data of the community. So the rationale is, as I've talked earlier, it's about very much low cost and convenience and measurement limitation at individual levels. So sometimes, particularly for this environmental contact, it's very much difficult to measure about individual exposure about, let's say, in a given room, if you are going to measure about the impact of, let's say, it between carbon monoxide in a different type of exposure, that is very difficult to establish at individual level consumption. In that case, we can have is the level of measurement within a given room. So within a given locality. So the limitation of this measurement at individual level can dictate for and the call for ecological studies. Other designs may be unable to measure about the different issues, and also sometimes we can be much interested in ecological effect instead of individual biological effect. So the data is, these are the main source of data. The source of data can be aggregate measured about the mean, the proportion, the prevalence, the incidence, average incidence in a given population, and then environmental measures about physical characteristics of place, for instance, about air pollution, fluoride content of the water. All these can consist about the global environmental measures, and some global attributes or global measures can be a source of data. So the source of data can be the different documented evidences from average measurement for the whole population that can constitute about the level of measurement. So as to the level of analysis, I think before the limitation, we need to look into the analysis. Analysis entirely is about correlating the evidences. So the correlating between the different average measurement across different population can be compared. And that says we can compute the correlation coefficient, and with this correlation coefficient, whether there is a perfect correlation or not can be ascertained whether there is the two variables compared are associated or not. But that cannot be casual link. It's not about casual linkage, but they simply show whether they are associated or not. That can also be further investigated by individual level data. So the analysis is entirely computing a correlation coefficient and also testing for significance of this correlation coefficient can constitute the analysis of the correlational studies. So as a limitation, these are very unable to link with an exposure to occurrence of disease in a single individual. So we do have an aggregate data. With an aggregate data, we can link an association between the two aggregate figures, but that cannot be linked into that individual level. So with this, it's very difficult to control for effect of confounder, whether there are some other variables can mask this association or not cannot be controlled with this correlation analysis and correlation the ecological states. But we do have there are some few mechanisms which you can handle this type of issues is about by running this partial correlation. So we can directly control for whether the effect of confounder is there or not. The other most important limitation is about ecological fallacy, which is a fallacy which is being committed by concluding the evidence that we have for aggregate figures for the individual. That's what we are committing a fallacy, because the data is all about an average exposure. It's about average of the whole population, but we are not going to, if we are going to attribute this exposure outcome association for the individuals, so we are committing a fallacy. That fallacy is what we call ecological fallacy. The most common limitation of this ecological series is about ecological fallacy, because it's very difficult to infer for the individual level data, the individuals based on the data from the aggregate of the population. So the other most important descriptive study is cross-sectional studies. So as its name indicates, this is an observational studies. So we are not going to interfere with the different types of exposure and outcome for individuals, but we are going to measure both the outcome and exposure at one point in time. That's the main essence of these cross-sectional studies. So we measure both exposure and outcome at one point in time. That can constitute the main features of this cross-sectional study. So the measurement is at one point in time, and we can have a measurement for entire population. We call it sometimes, we can also handle it about census. But if you have a large population, we can also have a representative sample of population, so that we can compute. We can also conduct, and we can also employ a survey, so that we can have figures for the population level description. Then the main objective of this cross-sectional study is to describe the population at a particular point in time. So we can describe with cross-sectional studies about the magnitude of the problem. So we can also describe about the problem under study with the different distributions across the different population of the person attributes. We can also describe the events across the different attributes of place and across the different attributes of the time. So these are the main objectives, to describe the situation or the health and health-related event occurring in a given community at one point in time with cross-sectional studies. So with the cross-sectional studies, we start with the study population, with those comprised of both individuals having the outcome and individuals having the outcome of interest and without the outcome of interest. At the same time, we are also measuring about the different factors or the different exposure variables. So with the cross-sectional studies, we sample individuals, and within the individuals, we measure both exposure and outcome at one point in time. This is the main dictated differentiation factor for differentiation element for this cross-sectional study. That's the main differentiating factor. It's about measuring both exposure and outcome at one point in time, so that we can, with this, if you have an ample evidence and if you have the sample size is large enough, so we can compute internal comparison, so that these cross-sectional studies can constitute both analytical component and that of descriptive component. So if you have an adequate sample size, so we can within the study population, so we can categorize individuals having outcome of interest and then without outcome of interest. So we can compare whether exposure have been present in the outcome of interest or not can be compared. So cross-sectional studies can constitute both descriptive and also to have analytical component, given that the sample size is adequate enough to address the different analysis. So these cross-sectional studies are most commonly used to study conditions that are relatively frequent with long duration of expression. That means if the condition is more prevalent, and the prevalence of the condition is higher in a given community, so cross-sectional studies are very suitable. If for instance, the occurrence is very much rare, it's very difficult to use a cross-sectional study to answer our research question under study, because the cross-sectional studies are being employed at one point in time. So we can miss individuals, with a long duration, long latency period of a different chronic conditions, or the different types of conditions that can take time for occurrence. So with this case, those cases that can non-fatal, but chronic conditions that lasting for long can be best suitable for measuring with the cross-sectional studies. So we simply measure about prevalence. So we can't measure about incidence or new occurrence. So with the cross-sectional studies, we answer about how prevalent the condition is in a given community. So we can't answer about how the rate of occurrence of certain health and health related event in a given community cannot be answered by with the cross-sectional studies. It simply answers about the prevalence, about the existing cases that's occurring in a given community. So it's not suitable for a very fatal with the case. If the case fatality rate of a given condition is very high, in that case, the condition not prevalent. So if the condition not prevalent, so this type of conditions are not suitable for cross-sectional study designs. So after having the data that gathered from the study population, then given that with the cross-sectional studies, we can have a data both for outcome. We commonly call the outcome the most common typical event in epidemiology. The most common outcome is a disease. So we can also, it can be a days, it can be days or alive. We can also have disease and no disease. So we do have a data for both disease and non-disease, and we can also data for both outcome and exposure at one point in time. So we can have data structure like this. So we can have contingency table. With this contingency table, so we can compare internally, we can compare whether the disease is highly occurring in a certain exposed individuals and not exposed individuals. So the main analysis that we can carry out for cross-sectional studies is, given the sample size adequate enough, so we can compare about the odds of exposure, and we can also compare about the odds of the prevalence among individuals who are exposed and without outcome and non-outcome. So these are the most typical data structures that we can generate from cross-sectional studies. So with the cross-sectional studies, we can answer about frequency. So we can answer about description. Even we can answer about the different association between the different variables by comparing and by computing odds ratio. That means odds of exposure among disease and non-disease. We can also compare about the odds of disease among exposed and non-disease can be computed, so that we can link between exposure and outcome of interest. So I think the advantage, the pros and cons of this the cross-sectional designs is most commonly the advantage of this is outcomes can be handled. The continuous quantitative disease outcomes can be handled rather than simple yes no categories for cross-sectional studies, but you can also have different proportion for cross-sectional studies, and case definitions independent of standard health systems can be used. So all these can be recorded. It's not just about iceberg. So we can define the case definition as both the standard definition, also with the different case definitions, so that we can handle all the cases, both the subclinical cases and also for the clinical cases. And these prevalence can be measured easily with the cross-sectional studies. We can also have a multiple cause of disease and consequence of exposure can be stated at with the cross-sectional studies with adequate sample size. But the disadvantage is it's very much inefficient for rare occurrence, and the rare occurrence most commonly labeled as when the occurrence is less than 10%, and some epidemiologists can take this as a rule of thumb as if the occurrence of certain illness or certain health and health rate event is less than 10%, so we can label this condition as a rare event. So in this case, if the condition is occurring at a rate of this less than 10%, So the cross-sectional studies are not more suitable for these type of conditions. So they're not suitable for disease of short duration and highly fatal and with a short duration of illness. The cross-sectional studies are not suitable. And the most important limitation for this is for this study design is about very difficult to unravel about temporal relationship. So we do have there what called the egg and chicken dilemma. So we don't have any, we can't establish the temporal relationship between the exposure and outcome, which is one of the integral part of the causality between exposure and outcome. So we can't establish a cause and effect relationship, and we can't also establish about the temporal relationship between outcome and exposure, because we measure both at one point in time, so we can't answer these type of questions with the cross-sectional studies. So these are the limitations of these cross-sectional studies. So another type of analytical study designs, the main purpose of all this, so far we have seen about how to describe the health conditions and how to describe the different health events in a given community based on different person, place, and time attribute, and also how to generate hypotheses. So those are the main concerns of descriptive studies. But epidemiology is the epidemiological concept. The concern of epidemiology is not about description, but it's also about identifying these factors under the basic assumption of about all diseases do have its own risk factors and also protective factors, and that can be systematically investigated. So under this assumption, the other concern of epidemiology is about identifying risk factors or exposure variables or determinants that can determine the occurrence of outcomes. And to do this, we can test hypotheses that can generated by our descriptive series, be the cross-sectional studies and also be with the case series and case report. So we can generate hypotheses that can be tested with this analytical. So the main purpose of analytical studies is to compare outcomes among different group of individuals, and so we can attribute a certain outcome interest for certain variables. So this is what's called linking association. And also we can also test hypotheses, whether hypotheses generated by descriptive studies can also be tested with these analytical studies. So the main features of all analytical studies constitute about, first we need to identify the key variables which are most commonly, we commonly measure in epidemiology. So the most common variable is about exposure and outcome. So we need to define what exposure is, and we need to define what outcome is. And we need to ascertain, we need to set forth about the criteria when to say an individual is exposed, and also we need to set forth when an individual has developed an outcome of interest or not. So the main key definition and the key identification of variables is highly also one of the integral part of conducting analytical studies. The next thing is about linking this exposure and outcome of interest. And after defining exposure and outcome, then the next thing is about formulation of hypothesis by linking the exposure and outcome of interest. Whether the exposure outcome are high linked or not. And with the yesterday's presentation, I hope you have we have rented about the hypothesis and a tentative solution for a certain outcome, the tentative solution for a certain issue or a certain phenomenon, so that we can formulate, we can link exposure outcome can be linked with a different hypothesis, so we can test whether that hypothesis is working based or not. And then after formulating the hypothesis, the next thing is about comparing the experience of a different group of individuals. So this different group of individuals can be group of individuals with outcome of interest and without outcome of interest, or the group of individuals with exposure with and without exposure individuals can constitute a group of individuals. So we can compare whether the outcome among exposed and exposed, and also we can also compare the exposure among individuals with outcome and individuals without outcome of interest. So this can also be best suitable for testing hypothesis, whether that is the statistical significant or not can be tested, whether the hypothesis working based or not can be tested. So these are the main features of analytical. So all analytical studies should go through these series of steps about identification of variables, the key variables, exposure outcome, and then hypothesis formulation, and the comparison of experience of the two groups of individuals, and those can be identified based on their exposure or based on their outcome of interest. That can also constitute for the different types of study designs, and then so we can test for hypothesis in the analytical studies. So I think the exposure in epidemiology refers to is about the different behavior individuals, can be trait of individuals, environmental factor, any characteristic being investigated as a possible cause of certain outcome interest can be labeled as an exposure. So we can say an individual behavior can be an exposure, an individual exposure to certain environmental factor can be an exposure, and even an individual different traits about it being its age, being in a younger age, older age can also be a factor that can contribute for the occurrence of outcome of interest can be labeled as an exposure. And most commonly, these factors are also called risk factors, and also explanatory variables and determinants and predictor variables. All these kind of variables that can explain the outcome of interest are what are called exposure variables. And as we deal it in our different statistical methods, and different statistical methods might require about the different models might require about explanatory variables or predictors and without outcome variables. So the exposure variables can constitute these explanatory variables, and that of outcome variables constitute about the outcome of interest. And the most common outcomes in epidemiological studies is about occurrence of disease and the disease consequence. It can be death, it can be disability, it can be different prognostic qualities and the prognostic indicators. All these constitute about outcomes that can be linked without the exposure of interest. So these are the key variables. So we need to measure them and we need to critically define what exposure and what outcome is. These are highly required for conducting analytical studies. So the association or the hypothesis is about simply showing the statistical dependence between the two variables, whether the exposure is linked with outcome of interest or not. Is the certain variable the risk factor for outcome of interest or not? So this the linkage between these two is what we call it what association. So association can be exposure can be associated with outcome, and outcome can also be associated with exposure. So this the statistical dependence we call it what we call association. And in generating hypothesis and expressing different type of hypotheses, so we in generating hypothesis based on the different types of descriptive series and based on our description from descriptive series, so we can suggest or tentatively we can suggest about relationship between a specific exposure and that of health related event. For instance, we can link between the high cholesterol intake with that of development of coronary heart disease. So as an hypothesis, that hypothesis can be a high cholesterol intake is associated with the development of coronary heart disease. So this can be an hypothesis. So we are going to use whether we are going to test this hypothesis can be an assignment. So the cholesterol intake is constitute an exposure, and that of the outcome is the coronary heart disease. So we are linking whether this cholesterol intake is that of coronary heart disease is associated or not. This can be one of the ways with which we can express our hypothesis. So in our yesterday session also we also dealt with about different types of hypotheses, and we have this null hypothesis and alternative hypothesis. And the claim that we have by researchers is can constitute about alternative hypothesis, and because it's very difficult to test all alternative hypotheses, but we are using the null hypothesis as a complement of this alternative hypothesis, so we can test whether based on the result of the null hypothesis, we are concluding for the alternative hypothesis. So the alternative hypothesis constitutes about our claim. It's about tentative solution that we give for exposure and outcome of interest. And the other suggestions or ways of expressing hypothesis can also be a cause and effect relationship. So we will have a talk on that about the difference between cause effect and that of association. So association doesn't mean that there's a cause and effect relationship. The cause and effect can be quite different from that of association. So we can also suggest, and we can suggest as an hypothesis that certain factor can be a cause of certain outcome of interest. For instance, cigarette smoking is a cause of lung cancer. So this cause could be sometimes a sufficient cause, and that this cause can also be constituted about necessary condition. So we can attribute a certain illness and be a necessary cause or also a sufficient cause. So this can also one of the ways of alternative of the expressing our hypothesis limitation with the different types of analytical stages. The other ways of expression of hypothesis, our hypothesis can be of a different type. Statistical test can be a one-sided test, or it can also be a two-sided test. So for instance, in the case of one-sided test, we are going to use about the increased risk of certain outcome of interest. So we are testing at one side. So we are using testing at the higher level, or so we are testing to the lower level of the test of statistical testing. For instance, H. pylori infection is associated with increased risk of stomach ulcer. So we are testing at upper tail test. We are going to use upper tail test. But if you are testing, for instance, weightlifting is associated with the risk of low back injury. So this association could be it can be reducing the low back injury, or it can be associated with increasing the low back injury. So in this case, we have two directions. So in this type of hypothesis test is what's called a two-sided hypothesis. So our hypothesis can be tested in the analytical series can be of one-sided, or sometimes can also be a two-sided test. So most applicable is both two-sided and one-sided tests can be conducted. So the guideline is it's better to have a very specific and very exposure can be measured as specific as possible. At the same time, the outcome has to be very much specific as possible. Otherwise, it's very difficult to measure to ascertain about exposure and also to ascertain about the outcome of interest. So while we are developing a hypothesis for being tested for our analytical study designs, so we need to be specifically and very clearly and also very specifically defining what exposure is, what's going to be, how good exposure is going to be measured, and then how the outcome is going to be measured. That can be a very important issue while we are ascertaining exposure and ascertaining assessment of outcome of interest. So the next thing is after linking all both these exposure and outcome variable, the next is about where we need to measure about the effect, whether the exposure has resulted in effect or not, and either the exposure has resulted in some effect or not. So this is what called a measure of effect, and we do have different measures of effect for measuring whether the exposure is attributing, or the exposure is attributable factor for occurrence of outcome of interest or not. So with this, we can this can be used to evaluate whether the research hypothesis is working based or not. So we have formulate hypothesis. This hypothesis can be tested by measuring the effect. That's the effect measured between the exposure and outcome of interest, and this can also reflect the disease experience of group of persons with and without the exposure of interest. Sorry. And if we are dealing with the different types of sample surveys, so with the same sample survey, we simply generate the point estimate. As about the inference, the point estimate is the best guess estimate that you can generate from the sample. But our ultimate goal is not only for concluding for this sample individual. So we need to look into the target population or the reference population for whom we are going to work. This evidence is going to work, and based on this point estimate, we need to generalize for the whole population. So this point estimate can be the point estimate within the sample can be measured by measuring the different effect between the exposure and the outcome of interest. And the most common types of effect measures are broadly they are categorized into the ratio measures and that of difference measures, absolute measures and that of ratio measures, or sometimes we call it relative measures and that of absolute measures. So the relative measures constitute about the most common relative measures are relative risk. So when you are comparing the risk of occurrence among different individuals, group of individuals, and we can also compare about the rate of occurrence across different individuals. So by risk, we mean is about if you are competing, let's say with the incidence proportion, or less we commonly call it the cumulative incidence. If you are comparing the risk or cumulative incidence among a group of individuals, we call it the relative risk. And if you are competing sometimes about rate of occurrence, we call it incident rate. If you are competing the incidence rate of a certain occurrence of event of occurrence across different group of individuals, we can compute about rate ratio, or this rate ratio, relative risk, and sometimes for odds ratio, and this odds ratio all constitute about the relative measures of effect. So with these measures, we can say that whether the factor being stated as exposure is associated with that of outcome of interest or not. And the difference measures, the most common difference measures are by this is the absolute difference between the occurrence of outcome of interest among different exposed and non-exposed groups. So we commonly compute this what called risk difference. So with this we can attribute a difference. So we can compute attributable risk difference. We can also compute about the attributable population attributable risk difference, and with this different type of risk difference, so we can also suggest about the impact of the effect or the impact of the exposure. For instance, what's the impact of removing a certain factor within a community, within a given community? For instance, what's the impact of, let's say, banning, let's say, salt intake or banning the cigarette smoking on incidence of lung cancer? So we can compute we can answer this type of questions by computing a risk difference. So we can compute an excess risk, which is attributed to certain factor of interest or exposure variable. So we can attribute that can be a risk factor, and then this can also be very helpful for particularly for policymakers and evidence the intervention designers or program designers. They can use about what's the impact that can be brought by banning certain outcome of interest, banning a certain exposure variable for a different outcome of interest. So these are the different types of effect measures. It's about odds ratio. It's about also the incidence, the ratio, the relative ratio measures, and also that relative measures and that of the absolute measures. So, for instance, by odds ratio, this the most common contingency table that we can encounter in ecological series is about this is the most common contingency table. So this D plus corresponds to the individuals with outcome of interest, and D minus corresponds to individuals without outcome of interest, and E plus corresponds to the exposed individuals, and that of E minus corresponds to the individuals who are not exposed to the variable under state. So the first thing for computing the different effect measures, so we need to compute whether what was the steady population. So were the steady populations exposed and exposed for outcome of interest, or where we started individuals with outcome of interest and then we go back to measure exposure or not. If you go back to the exposure based on the outcome of interest, then we can compute what we call odds ratio. So with odds ratio, we can answer about the odds of exposure among individuals with a disease and without a disease, and then we can also compute the odds of exposure among individuals with a disease or without outcome and without the outcome of interest. So this is the main typical computation formula for computing odds ratio. So odds by itself is a ratio because odds also it means that odds is the ratio of occurrence to non-occurrence of certain event. In the probability, if you compute the odds of a certain event, is to mean that it is the ratio between occurrence to non-occurrence of certain events. So if this ratio, the ratio is going to be computed for finally coming up about the odds ratio. So this AD over BC constitutes about the odds of exposure among outcome, and then the odds of exposure among individuals with disease and non-disease, and also the odds of disease among exposed and non-exposed can also be answered by odds ratio. So this is the way, if you compute this for the same table, if you compute the relative risk, the risk is about the risk of occurrence of certain outcomes. So by risk we mean individuals who are at risk of developing certain outcome of interest, then we can compute what the risk of observing the new outcome of interest within that population under study. So that risk can be computed. For instance, if individuals exposed and non-exposed are followed for a certain period of time, then out of the total population of A plus B who are exposed to certain variable, then the number of new occurrence individuals who have developed the disease constitutes A. So A over A plus B constitutes about the risk of observing outcome or the risk of observing disease among individuals who are exposed to the variable. And then among individuals who are non-exposed, those constitute C plus B. So the number of occurrence of outcome interest is observed among individuals who are C. So C, the ratio between this C to C plus D constitutes, it's not a ratio, it's a proportion. This C over C plus D constitutes about the risk of observing outcome of interest among individuals who are non-exposed. So we can compare whether the difference in the risks among exposed and non-exposed, so that we can attribute whether the factor under study or the exposure is a risk factor or it's a protective factor, can be or not. So sometimes if the outcome is very much rare, so odds ratio can also answer about the direct estimate of the risk. But in that case, the figure that odds ratio can also estimate about the odds ratio. So the other condition is the first thing when the odds ratio can estimate for the relative risk is when the outcome is very much rare. So we can estimate both the evidence that we generate for odds ratio and the relative risk can be the same or almost equivalent and almost very close to each other. But at the same time, if the effect size is very much small, that means if the effect size is to mean that the odds ratio, but the ratio, the quantity of the odds ratio is very much small. So in that case, the odds ratio can also be used to estimate for the risk of outcome that outcome of under study. So these are the conditions that we can compute. You can see this figure. So in this case, the risk is the estimate, the effect size for odds ratio is about close to 1. It's about 1. And then if you compute for the same figure, we can also come up with the relative risk of 1. If the effect size is very much small, means the effect size is very close to 1. If the effect size for odds ratio is very close to 1, so that estimate can be a best estimate for the relative risk, because that risk estimate is the estimation of the direct estimation for risk of incidence of certain event. So these are the main features or the main issues that we need to deal into the analytical studies in general. But these analytical studies can be broadly classified into observational and experimental studies. So with the analytical studies, we can answer about the etiological agents of certain event of interest, and we can also answer about the risk factors of event of interest or not. So to answer this question, we do have two basic approaches. So the first approach is about observational. So as its name indicates, we are simply observing what's naturally occurring and what's the naturally occurring phenomenon. We are not going to interfere about the individual's exposure status. So we are not going to expose individuals, but we are observing individuals who are exposed by themselves. So investigator in this case is very much passive. We don't have any active involvement of the investigator in assigning exposure or so in controlling about the amount of exposure. Even about the level of exposure cannot be controlled by investigators. That's why it is simply observation. So that's why even the category, the name of the category is labeled as observational, because we are simply observing what is naturally occurring, but we are not interfering. The other approach of dealing with different analytical studies is about experimental. So in this case, the main difference with the observational studies is with experimental studies, we are going to experiment human being. We are going to experiment them. So the investigator is very much active. So investigator is going to assign the exposure status to individuals. So the exposure is going to give drugs, for instance. The exposure is going to give a vaccine for certain individuals. So the investigators can use different interventions for different community. So the investigator can also refuse or deny any services or intervention for certain group of individual or community. So in this case, the investigator do have an active role in assigning the levels, the control about the different types of exposure levels for individuals. So this is the main difference between observational and experimental studies. So with the experimental studies, if the investigator is going to assign this exposure, if this assignment is on the random basis, we call this type of experimental studies are randomized studies. So the randomization is if the exposure variables is randomly assigned, so these are randomized studies, but experimental studies can also be non-randomized. We call it also commonly called it a price experimental study. So these studies, the exposure assignment is not random, but it is assigned by the investigator, but the assignment is not random. If the assignment is random, So we call this type of experimental studies called randomized trials. So this both observational and experimental studies constitute the analytical studies. I think these are the different features that we have described earlier. Observational, we don't have any experiment. We treatment and exposure occur in a non-controlled environment. That means the investigator cannot control about the treatment and exposure in the case of observations. We simply observe what is happening naturally by natural exposure. So the other experimental studies can also be further classified. The experimental studies can further classified into the randomized clinical trials, when the trials or the investigation can be carried out at the clinical setup. We call it the clinical trial. I hope we will have also a separate session for the clinical trial in our subsequent training sessions. And then about field trials, community trials, based on the different types of situation and setting. So we do have different types of control trials. For instance, randomized control trial, clinical trial, which are most commonly dealt with about clinical aspect, about therapies, about different types of diagnostics. So we can evaluate about this with the clinical trials, field trials, so about most commonly for involving healthy individuals, so that we can investigate, or we can also evaluate whether a certain intervention can work best way to effectively prevent occurrence of outcome interest or not. And we can also use the community as a cluster. So we can have a cluster randomized trials at different community levels. And the other observational studies constitute cross-sectional studies. Cross-sectional studies can also be both analytical and that's also this descriptive series. So we can use cross-sectional studies, and the most other important aspect of these observational studies are case control and the cohort studies. So we'll have a brief description of these different studies. We have dealt with about cross-sectional studies, but we'll be describing and talking on cohort studies and case control studies. So one of the main content in the definition of epidemiology is about identifying determinant factors and risk factors. And the way we identify different determinant risk factors is either we can start from outcome of interest and we can go back whether those individuals do have a risk factor or not. So the other scenario is we can measure the exposure and then we follow them whether that outcome of interest has occurred in that individual or not. These are the two main ways with which you can ascertain the outcome of interest, or we can also experiment them whether the outcome can be prevented or the outcome can be determined by the different types of exposure variables. So the case control study is a study that starts with a case. By case, we mean individuals with outcome of interest. That case could be an individual with a disease, or a case could be an individual with a disability. A case could be an individual with the different types of days, or individuals who are diseased can also be considered as a case. So case is to mean that it's not a clinical case. So by case, we mean it's about individuals with outcome of interest can be labeled as a case. So we can start the main essence of these case control studies are the study population are going to be selected based on their case status, based on the outcome status. Individuals with outcome and individuals without outcome is going to be selected, and then the exposure is going to be measured whether these individuals do have the different risk factor or not. In the case of cross-sectional studies that we have seen earlier is in the cross-sectional studies, we entirely measure the whole population, and then we entirely measure the whole population, the study population, and come up with the measurement for both the exposure and outcome at one point in time. But in the case of case control study, we select individuals based on their outcome status. That means individuals with a case, individuals with outcome, and individuals without outcome. For instance, individuals with certain disease, with lung cancer and without lung cancer. And then we go back to whether these individuals to have been smoking or not. So this can be one of the typical case control studies that can be designed. So the case control is the exposure, the variables can be measured respectively. So in this case, both outcome and exposure, both exposure and outcome has already occurred. But we start from the outcome and then we measure whether the subjects are exposed to certain variable or not. So this is the main essence of case control. So in the case control, the main starting point for the case control study is starting from the disease. So individuals with disease and without disease is going to be selected, and then we retrospectively measure about their exposure status. So as from these pictures, we see that first we need to classify our study population to the individuals with outcome and without outcome of interest, and then we are going to measure about the different risk factors. So first we need to measure at the present time individuals who have outcome of interest. Then we don't know whether these individuals have been exposed to certain variable or not. So to do this, after categorizing individuals having outcome of interest and without outcome of interest, then we go back from the history and from the different measurements. We are going to ascertain about the exposure status, whether they have been exposed or not. Then we are going to attribute whether that exposure is attributed to a factor that is either protecting or also either also determining the occurrence of different outcome of interest. I think these are the different ways with which you can we design a case control. So with the direction of inquiry is backward, and at the time of study we need to select individuals based on the case and based on the outcome. So participants are selected based on their outcome status, and exposures are measured retrospective backward and historical measurement. So these are the main features and the design features in the case control studies. Is the first and the most important thing is about we need to define who are the cases. So we need to have a very explicit definition about the case. So when you say individual to have a certain outcome of interest or not, for instance, if you are measuring about, let's say, lung cancer, then we need to have a very clear definition about who is going to have a lung cancer or not. So we need to have a very explicit and very objective definition for cases and about lung cancer, related for instance about lung cancer. Then after defining and measuring and ascertaining about the cases, the next thing is about who are the control groups and who are going to be comparator for these individuals. So we need to define who are the controls, and we also need to select about the different controls. These are the procedures where we need to look into the case control states. So after critically defining and selecting both case and controls, the next thing is about ascertainment or measurement of exposure. So what are the key variables or the key exposure variables that can attributed to be the cause or the risk factor for this outcome of interest? So we need to have a very key definition about ascertainment of exposure. So we need to have a very key definition about when you say an individual is going to be exposed. And for instance, when you say, let's say, if you are going to attribute smoking with that of lung cancer, so we need to have a very key definition about when to ascertain an individual to be smoker or not. So we need to have a very clear definition. So is it smoking one packet of cigarette per week and one cigarette per day, and let's say 10 sachets of cigarette per day? So it's a very clear definition about whether an individual is smoker or not. Need to be a very clear definition. So we need to have a criteria for assessment of exposure. Then after having this all data on outcome and exposure, the next thing is about data presentation and data analysis. And the data presentation, we need to look into the data, the data for the case and data for controls, and then about their exposure status. Then we are going to link them with the different measures of effect so that we can attribute whether that outcome of interest is linked to the outcome of interest or not. So these are the main structure of the case control research. These are the main structures that constitute the case control research. So we need to have a section for defining, selection, case control. We need to have a section for definition and definition and selection of controls. We need to have a section for case exposure ascertainment, and data analysis should have very key definitions. As a case definition, sometimes if we are going to deal with the clinical and subclinical cases, so we can define the case for our purpose, for the purpose of the research purpose. So we can give a definition. So that definition can be a standardized definition, or that definition can also be some operational definitions that can be coined by the investigator, so that can label individuals for outcome or without outcome, and without outcome of interest. So further, we can also classify them based on the clinical, confirmed, probable cases, and different criteria based on the different criteria. So we can set forth a criteria for identifying a case of individual. The next is where to find the case, also another option, section for the case control research, where to find the case. For instance, if you are dealing with, let's say, if I want to answer the cause, what caused the death of these individuals, so we need to look into the case, the deaths from the hospitals, the hospital data, then we look into back to whether they have been exposed to certain variable or not. So most of the cases we can find cases from the hospitals, be it a death, be it a disability, be it a disease. We can find the data from the hospitals, and sometimes we can also have a population level data. So we can have a survey, so we can have a census of cases, and we can have a census of control, so that we can have a better representation of both case and control. So the main source of based on the different resource limitations, so we commonly use the hospital or health facility level data, but the most common value data is the data from the population level, because that can avoid the different bias that can be introduced during selection. But it's not common due to the different logistics and cost reasons. And these cases can be, the selection of the case can also be based on random basis, and sometimes you can also restrict to the different population, different focus and very critical group of individuals. So the main focus of this selection is all about to ensure whether our data is going to be internally valid or not. So to ensure a better internal valid data, so we need to look into our selection of series subjects. About measurement need to be very much clear enough so that we can be sure that our data is very much internally valid. So these are the main source of data for cases. So for ascertainment of disease, when you say individuals is going to have a disease, so we can have, if you have some basic registers, for instance, for cancer registers, we can have a physician's report, so we can have hospital admission or discharge records, different pathology departments. So based on these are not exhaustive lists, but these are the most common source from which we can ascertain individual disease status. So we can ascertain the disease status from their individual case registers. We can also from the different registers entirely from routine data from the health facility. So with this, we can ascertain whether individuals do have a disease and individuals do have outcome of interest, let's say disability or death. And the controls, by controls, we mean the controls are subjects who are free from the disease. It's not only disease, but free from the outcome of interest. For instance, if you are dealing with, let's say, for the cause of death, so individuals who are alive can be a control. In this case, the death individuals can constitute about case, and also individuals who are alive can constitute about the control. So individual controls are the comparison groups who are free from outcome of interest, but as much as possible, they are very much similar with that of the the cases. So they are assumed to be disease-free if they have not been diagnosed. Usually they are assumed to be disease-free if they are usually not diagnosed with the cancer or whatever different disease under study. So we can label them, these individuals can be controlled. So controls are individuals who are free from outcome of interest, but they can be similar with other parameters, other attributes of the cases and with the cases. So while we are selecting the controls, so we need to look into the different criteria that we use for the case that also should also work for the controls. So the controls can also be selected from the same source population from where the case are also controlled. That can also ensure a better validity and better internal validity. So it's recommended to select both case and the control from the same source population so that we can prevent the different the source of bias that can be encountered due to this selection bias. So the control should also come from the same source population as the case, and also they should have also the opportunity to have a disease if they are diagnosed, if they have the chance and if there are opportunities, they can be disease. So that this shows that the control should be as much as possible similar with that of the cases, but they should be different with outcome of interest. So the other thing, the time during which the subject is eligible to be controlled should also be the time in which the individual are also eligible to the case. So the timing should also be the same for both case and control. So we should be very much curious enough in using these the same criteria for selecting both case and controls while we are designing a case control state. So the main source of the controls, so we can select a control and comparator for our cases from general population by different surveying or census from these different random digit dialing, neighborhood, and sometimes friends or relatives. The most commonly these friends and relatives is if you are dealing with a different genetic type of disease and different types of genetically linked disease. So it's most recommended to have friends or relatives to have the relatives to have a better comparator for the controls for different diseases. But all these do have different their own advantage and disadvantage. But if you are using this for instance general population, so we can ensure a better representativeness of the controls, but it can be very much costly to have a general population or population representative controls. And random dealing can also be it can also cannot be representative for instance, particularly for developing countries. Very difficult to have a random digit number because most people might not have these different these numbers, so that can be the other responding. So in the neighborhood, there can also be different types of bias can also be introduced because they do share the same environment, they do share the different environment, they do share also most issues within the neighborhood. So that can also be some source of bias. So all these might have their own advantage and disadvantage. So we need to outweigh their advantage and disadvantage so that we can use one of the main source of controls for our cases, and depending on the type of case that we have. As a sample size, so the next question that we need to answer is about, I hope also we have discussed this about sample size computation about with yesterday's session. So the sample size, particularly with the case control, is about how many controls to be sampled for the case. So that depends also on the prevalence and the occurrence of the certain cases in a given community. But the controls, the most of the time, the one control is optimal for the one case groups. But more than one control group might be needed, but this cannot increase the power of the test. So particularly some such chance, and also it always recommend that exceeding, let's say, a control to case ratio, let's say about 4:1. So if you are exceeding, let's say 5:1 or 6:1, so you don't have any increment in the power of the test. So it's simply a wastage of resource. So it's not recommended to have a ratio between case and controls to case not more than 4:1. But in most cases, 1:1 suffice for dealing with the case control stages. So I think that sample size, as with the yesterday's description, so sample size can be computed by using the different statistical softwares, and we have different open statistical software that can sample size calculators. So with this sample size calculation, we need to look into about the first, we are going to compute individuals with outcome of interest and without outcome of interest. And we are going to test whether with exposure status. We need to input, there are inputs required for sample size calculation. For instance, the EP info stat calc program is, the first we need to know the effect size. That's based on the hypothesis being measured, and then the effect size, the proportion or the prevalence or occurrence of the exposure among the cases, and exposure among the proportion of exposure among the controls. So these are the main inputs that we need to input the sample size calculation. Also, we need to also input about the significance level, that is the level of confidence that we have at the end of the data analysis, and the level of confidence and the power you are intending. So based on this input, I think it's very simple to compute the sample size required for how many cases and how many controls to deal with a case control study. So after computing all these samples, the next thing is about measurement. So the main measurement issues in the case control study is about measuring exposure, because we have already measured the outcome. We have already known the outcome of interest, whether individuals with outcome and without outcome of interest. So the only thing that we have, the main measurement issue is measuring our exposure, and how we're going to ascertain individuals who are exposed and unexposed. So for this, we can employ different techniques and different measurement issues. So the source of exposure data can also be based on interview of individual. For instance, have you been smoking or not? This can be one sort of ascertainment of exposure. Interview of caretaker, particularly if you are dealing with the children and different types of individuals who are seeking different types of care. So we can interview individuals with a caretaker or closest person. So we can also review different medical records, and you can also use biological samples, whether individuals have exposure, different serum levels of different chemicals can also be measured, whether that individuals have been exposed to certain variable or not. So these are the main measures of exposure. So it is advisable to use objective recurrence rather than subjective measures, because so it's advisable to use standardized questions posed for the case and controls, and then to avoid these different types of bias while measurement, and which most commonly this measurement bias. So we need to blind the investigator to the outcome of the patient, so that individuals can do the similar procedure for both the case and control, so that we can also avoid the bias that can introduce during measurement. So it is advisable to blind the individuals, particularly the data collectors, who is the case and who is the control, so that we can have a better information, the better evidence, so that we can control for we can also minimize the effect of measurement bias. So after measurement, with the case control study, we have started with the outcome of interest. So we know individuals, the A plus C and the B plus D are already known. Our sample size constitutes about A plus C and B plus D constitute our sample size. Then what we did was with the case control study was about whether these individuals A plus C do have exposure, yes or no. And then whether these individuals B plus D, who are the controls, do have the exposure, yes or no. So after measurement, out of these A plus C individuals who is the outcome of interest, then A consists about individuals who have with the exposure status. So with this measure, because both outcome and exposure have already occurred, it's very difficult to measure about the risk of occurrence. So in this case, what we can do is we can measure the odds of exposure among individuals with outcome of interest and without outcome of interest. So we can compute the odds of exposure among the case controls by using an odds ratio that you have seen previously. So with this odds ratio, the proportion can be compared, whether the proportion of exposure among case and exposed can be compared by different Pascal tests, particularly with this chi-square test. With the chi-square test, we can compare whether there's a proportional difference between the proportion of exposed among individuals case and control can be computed. And when the different assumptions fail, you can also use a Fisher exact test, whether the associations are statistically significant or not. Then with the measure of association, the main association that we can compute with from the case control study is computing odds ratio. So with the odds ratio, we can answer about the odds of exposure among case and control, and based on the magnitude of the magnitude of the odds ratio, so we can ascertain whether the exposure is a risk factor, whether the exposure is a preventive factor or not, can be ascertained based on the figures that we have. I think this is the way how to compute for how the odds and the odds ratio are related. The odds is simply, it is P over 1 minus P. P stands for the proportion of occurrence, and 1 minus P, where because occurrence and non-occurrence for most dichotomous variables they are mutually exclusive. So we can say that the occurrence, where the occurrence is P, then the non-occurrence is 1 minus P, because the two are mutually exclusive even. So the ratio between this P to P over 1 minus P constitutes what we call odds. So based on these odds, so with this formula, we can finally come up with about computation of the odds ratio. For instance, the first A over C constitutes about the probability of disease. The probability of disease person being exposed is about A over C. And this can be also computed and finally come up with, if you derive this formula, it's very simple to derive. And so if you finally drive up this formula, then finally we come up with about AD over BC, when A constitutes with the individuals who are exposed and individuals with the disease, and D constitutes individuals who are without the disease but we are not. The both A and the D consist about, these are the concordant pairs, and that of the discordant pairs B and C. So the ratio of concordant to that of discordant consists about these odds ratios. So all about AD over BC consists about odds. So based on this figure, based on the figure that we have from this AD over BC, if this ratio constitutes, the ratio measure consists about, if it is 1, so this one shows that there is no difference in the odds between those individuals who are diseased and with those individuals without the disease. So in this case, the exposure variable is no more associated with that of the outcome of interest. So if this odds ratio is greater than 1, this shows that the odds of exposure among the cases is much higher than that of the odds of exposure among control, so that the exposure can be attributed as one of the risk factors and the more likely to develop the outcome of interest among the exposed variables or not. So based on the figures, if it is 1, there is no association. If it is above 1, so we can say that the factor, the exposure under the study can be a risk factor. And if this the figure AD over BC is less than 1, so that the factor under say is not, it's not a risk factor, rather it might be a protective factor. So we can ascertain whether that factor is not a risk factor. So this is the way how the epidemiology and the basic assumption of epidemiology about, one of the assumptions is about there are factors that can be a risk factor or there are factors that can be a protective factor. So this is the way how to identify whether the factor is a protective or the factor is a risk factor with the competing resource ratio. And as in our earlier talk, so we have discussed about how the relative risk and odds ratio are related. So the relative risk and odds ratio can be related when the effect size of this odds ratio is very much minimum and also very small, and that's very much close to 1, or which you commonly call the null value. So we can use this odds ratio can be estimate the direct estimate of the relative risk, right? And otherwise, odds cannot estimate a direct risk. So we can't say this factor is risk factor with the risk factor of a certain outcome interest with simply computing odds ratio. But this can only work only when the effect size is very much small and also the condition is very much rare. So the main strength of this case control series is compared to other observational studies, and this is very much inexpensive compared to the other analytical studies. So this is very much well suited to evaluate disease with long latency period. For instance, if the disease to require a longer period to observe for outcome of interest, so it's very difficult to design such type of cohort study. So in this case, the only alternative what we have is designing individuals who have the case and the control. Then we'll go back to the exposure variable. So the most suitable design for this type of condition is designing a case control study. The other is very optimal for rare disease, and though with the case control series, we can study multiple factors for outcome of interest. For a single outcome of interest, so we can ascertain multiple outcomes or multiple exposure variables. This is also one of the advantages of a case control series. So because we started from the outcome, then we can ascertain many exposure variables beyond that of our main exposure variable. So we can identify some other variables. So that is very much suitable for identifying multiple factors responsible for the occurrence of outcome of interest with the case control series. Associated limitation. So because both outcome and exposure have already occurred, though we have started studying from the individuals who have outcome of interest, but we are not sure whether the outcome preceded the occurrence of exposure or not. So in this case, we cannot establish temporal relationship. That's why we are not there to say the odds ratio cannot be direct estimate of risk. So we are not sure that the outcome preceded the exposure preceded the outcome cannot be ascertained with the case control series. This is also one of the limitations of case control series. The other is very much prone to the bias, particularly selection and recall bias, because the selection most of the time, most cases can be selected from the hospital and the different healthcare setups. So that cannot be representative of all the cases, because particularly in the developing countries, very few individuals can seek care for different health events. So majority you are dealing only with the iceberg. So that case, the cases cannot constitute or represent for the whole population of the cases, and also the controls can also be represented for the whole control, so that we can be prone to have both selection and recall bias. With the recall bias, because we are entirely dependent upon the recall of individuals or recall of different previous history of individuals. So if you are dealing with the data for 10 years, about 5 years, and 5 years and later 15 years, so it's very difficult to have better data quality, so that it's very much biased, prone to have recall bias in the case control sets. Cannot usually provide information on incidents. So we simply give about the prevalence, the odds of disease, but we can't directly estimate about incidence with the case control studies. And also it cannot be usually study rare exposure. So though it is very much suitable for rare outcomes, So these case controls cannot be suitable for rare exposures. So it's about rare exposure, but it's suitable for rare outcomes. So to deal with this difference, to deal with the different limitations of case control studies, we did another observational study, which is a better, stronger study with that of case control studies, what to call a cohort study. Also, different types of cohort studies can be designed. So by cohort studies is also an observational studies like that of the case control studies. So the main differentiating factor between the cohort and case control studies is in the case control studies, we start from individuals who are with an outcome of interest, and then we are without outcome of interest. We compare whether they have been exposed or not. And with the cohort, so one of the limitations of this case control study is about direct estimation of risk cannot be possible with the case control studies. To have a direct estimation with the estimation of the risk factor or risk between exposure and outcome, so we can start individuals who are exposed and then exposed, and then we look forward to see whether an outcome has occurred or not on that individual or not. So we can directly estimate the risk among individuals who are exposed and exposed. So the main difference, the comparative group or the being individual group of individuals who are going to compare in the cohort studies are individuals who are exposed and individuals who are not exposed, followed for outcome of interest. This is the main differentiating factor for case controls and that of the cohort series, the case control cohort series. So it's also observational series. So we are not, though we are starting individuals with exposure, then we are not intervening with the intervention levels. So we are not control about the amount of the intervention. We cannot control about the level of exposure. We simply observe that those individuals who are naturally exposed. So that's why it's observational, so type of observational studies. So the data collected most of the time, the data on beat and exposure and outcome can also collected prospectively. That means forward. So sometimes you can also collect concurrently at the same time. And then most commonly also we can also use retrospective measurement can also be possible for cohort studies. So with the cohort studies, first we need to go into the study population, and then before dealing with the data management, data collection, first we need to classify our study subject into individuals who are exposed and unexposed. So first, after defining and after putting setting forth all key definition for when individuals is going to be exposed and when individuals is going to be said to be non-exposed. So after defining the individuals, so we need to select our study subjects based on the exposure status. Then individuals who are exposed based on exposure status going to be followed for certain period of time for occurrence of outcome of interest, so that we can estimate the directly. So the timing is we are sure that individuals are free from outcome, but we are sure that individuals who have the exposure, but they are free from outcomes. Then we are following for the occurrence of outcome interest, which is not possible in the case control studies. So in this case, the time frame we commonly forward, we are measuring forward prospectively after measuring exposure status. After measuring exposure, we look forward to obtain or to ascertain whether individuals who have exposure or not can be ascertained by prospective. And this type of cohort studies, we call it the prospective cohort study. But sometimes in this case, we individual group categorize into exposed and exposed, and then follow for outcome of interest. So the outcome of interest can be ascertained in the future after attaining exposure. The exposures are ascertained, but outcomes not yet ascertained in the cohort study. So these are the designs. In the case of retrospective study designs, so in this case, though both exposure and outcomes are already occurred, but we can start based on the different registers and based on different documents. So we can start individuals based on the exposure status. So we are going to select individuals based on whether they have been exposed and non-exposed. Then we follow them. So the follow-up here is based on the history and based on their different documents and based on the different histories. And so that based on these different histories, so we can ascertain whether outcome has occurred or not. So with this, we can also ascertain the risk of outcome and then the different individuals who are exposed to certain variable. So these are also another option for case control. So the cohort studies. So cohort studies can also be a prospective when the outcome can be measured prospectively. When the outcome can be measured retrospectively, we call it retrospective cohort studies. So these are also some of the variants of the cohort studies. So to the feature, that means the component of these cohort studies. So the first and the most important thing is about defining exposure. Then we need to clearly set forth about what's the exposure, what's the variable of exposure, and then when you say an individual or group of individuals is going to be said to be able to be exposed or not. So we need to define critically and clearly and explicitly about exposure status, and then after defining this, we need to select about exposed. Who are the exposed groups and where to go? So where to find this source group is also one of the features need to be ascertained in the cohort studies. And then after this, then the comparator group, because we are going to compare them, the next thing is about defining an exposure. So after defining exposure, we need also the complement of an exposure. Who are the exposures and then where to find them also another section. And the other important thing which not there in the case control study is about the follow-up, because we are following the outcome of interest after defining exposure. So we need to set another strategy for retaining individuals within the studies, and how we're going to retain them to complete the study. That's about follow-up and retention mechanism should be there to have a better response, and also to minimize the different attrition rate in the different types of these course studies. And after maintaining individuals within the, after maintaining the compliance and after maintaining all the retention within the study, the next thing is about ascertainment of outcomes. And when are you going to declare whether the individual has developed outcome or not? This is also one of the critical elements of the course study. So we need to set for the clear definition and a very explicit definition about when to say an outcome, when you say an outcome has already occurred, and then when to ascertain outcome need to be clearly defined. And then finally, after defining all these outcomes, ascertaining all these outcomes, the next thing is about comparing the outcome and individuals are exposed and non-exposed. And how are we going to compare with? Is there a difference in the outcome rate of outcomes, or the occurrence of outcome and then exposed and exposed by using the different analytical techniques? I think for the source of exposed groups, the source of exposure group can also be, after defining exposure group, you can find exposure group from the population. So we can also find the population from the group of population. So we can have different special groups. We can have different occupational exposed group. For instance, some occupations are entirely dealt with a certain occupation, then we can entirely select the exposure individuals from the different specific occupation, can also serve as a source for the exposure group. So similarly, we can also select the group of individuals comparison group. In this case, the comparison group is individuals who are non-exposed. So this non-exposed can also be selected from the population or from the different types of self-report, and sometimes can also used by direct measurement. So we can have a different source of both the selection, both the exposure and non-exposure can be selected from the population, from the health facility, from the different neighborhoods. The different structure can be used for selecting both these exposed and non-exposed group. So after defining and selecting all these measures, the next thing is about how to ascertain exposure. So there should be a clear definition about exposure ascertainment. So the main source of this exposure ascertainment can be from the existing record, most commonly for retrospective cohort studies. So we are entirely dependent upon the pre-existing record. So the other thing, we can also use a self-report, for instance, for different issues and the different health outcomes. So for we can interview individual. For instance, if you administer certain drugs and if you are interested to know about the adverse effect of certain drugs, so we can interview them whether that the different signs symptoms have observed in that individual or not. So we can conduct a survey, so whether the outcome has already occurred or not. Direct measurement, whether on different types of measurements, different types of science can be measured by direct measurement, and we can also measure repeated measurement across different time spans. We can repeatedly measure whether there is a change in the trend or not can be measured. So these are the main sources and the main issues in measurement on ascertainment of exposures in cohort study. So typically, the most exposure variables can be it can be dichotomous. The most common types of dichotomous, whether they're exposed and exposed. But sometimes the exposure can be at different levels. For instance, the level at the mild level, the moderate level, and the severe level. These can constitute about intensity level. So the exposure variables can be in terms of dichotomy, yes or no, and in terms of intensity, in terms of different types of duration. For instance, the weeks, months, the daily, we can also have this, and also we can have the cumulative effect. So we can, for instance, pack of years of smoking, for instance, for a year, for 2 years, for 3 years, and about regularity, about frequency. So we can also categorize them as about frequent, about daily, weekly. It's about episodic. We can also have different types of regularity, and there is also variability, range of cardiovascular reactivity, for instance. These are the main issues in exposure. Exposure is not always about exposed and exposed. So we do have different categories. So we can have different levels of exposure. For instance, a single variable can have different levels of exposure, so that can be compared. So the exposure can constitute a single variable across a different group, or we can have a different variable across different groups can also be compared. So these are the different categories of exposure variables. That's not only about dichotomy, which is the most common, the dichotomous, but it's not only limited to the dichotomous, but these are also some range of exposure variables. The other thing is about, after setting forth all the exposure variables, the next thing is about how to maintain individual to be there within for the study period. So with this follow-up issue, we need to set for clearly about for how long we are going to follow, and then how to follow need to be very clearly indicated in this section. So the follow-up, the number of times or the time period should also dependent upon the outcome, the type of outcomes. So what type of outcome are we going to study, and how frequent that outcome can occur. and in terms of their cost, and what are the cost we have, the resource we have, the time we have. So depending on this, so we can limit the time of follow-up, and based on the biological plausibility and based on the different clinical soundness, so we can determine the number of times that we're going to follow. So after determining this, the number of times that we need to follow them, the next thing is about how to follow the number, also need to be clearly indicated. So the method with which you can follow them is, we can, for instance, if you are dealing with a different cases at a different homes, at different individuals, so we can have a periodic home visit so that we can ascertain whether the individuals have outcome or not. So the main issue or the main purpose of follow-up is to ascertain whether the outcome has occurred or not. At the same time, to ascertain about the time to event. So when this event has occurred. So we can also answer about the time to event issue. So at the same time, we can also answer about the risk of occurrence, the risk of observing outcome of interest at that individual. So these all both matters, both questions can be answered by the court study. So this can be done by periodic visiting, by sometimes per telephone calls, mail questionnaires, periodic examination, screening at different. It can be at the home or it can be at the facility, and this can be done at a different setup. So that these are the methods with which we can ascertain, we can ensure whether the best follow-up individuals are going to be maintained within the study. And this most of the time based on the conditions and based on the different types of illness and based on condition under study. So the frequency can be determined based on that. It can be on weekly basis, it can be on daily basis, it can be on monthly, it can be sometimes if you have a longer period of court studies, like that of the Feringham study for this cardiovascular disease, these studies, it can as long as about for 10 or 40 years. So in this case, we can have an annual basis follow-up. So the time of the follow-up depends on the type of or the event that we are studying or under study. Then how to ascertain whether the outcome has occurred or not. So these are the main source of information from each. So we can ascertain whether the individuals do have the outcome of interest or not. So it can be based on, particularly if the countries, the different countries or nations do have a different certificate of this vital registration for these days, different types of disease registration. So we can ascertain the outcome of interest from that day certificate. It can be from clinical history, it can be from self-report, it can be from medical examination that we had it in our follow-up period during the periodic examination of the court period, the court individuals. And we can also use the hospital discharge when the discharge logs do have a different discharge with days, discharge with improvement, and this depending on the different types of event under study. So we can make use of all these sources to ascertain whether the outcome has occurred with that individual. But prior to that, we need to set forth when an individual is going to be labeled as with outcome or not. And the outcome need to be very clearly defined. But these are the source of information from which we can ascertain a case. So we can ascertain an outcome of interest or not. So after ascertaining all the outcomes, so at this stage in time, so we have already classified individuals we have started individuals with exposed and exposed, and then we followed them for a certain period of time, which is dependent upon the type of outcome. Then we ascertain the outcome, and that was defined ahead. So we have defined the exposure, and also we have defined also the outcome of interest. The next thing is about how to link this exposure and outcome of interest. So as analytical studies has already have a hypothesis being tested. So based on that hypothesis, so what was the key exposure variable that was hypothesized to cause this outcome of interest? And then we are going to link with a different type of data. We are going to link the exposure with that of the outcome of interest. So we are going to list the association between exposure and outcome of interest. So because we have started individuals with exposure, those individuals who are free from outcome of interest, so we can directly compute the risk of occurrence of outcome of interest. So by direct computation of this risk of interest, the risk of outcome of interest, can be computed by making use of different denominators. For instance, if you are entirely dealt with the cumulative incidence, and if you are dealt with incidence ratio or incidence proportion, so we can use the denominator, the whole denominator population exposed, the whole exposure individuals to be taken as a denominator, and then we can divide the number of new occurrences of outcome and those occurred in that group, and divide by this, we can get the risk of observing outcome among this group of individuals. But sometimes in practice, but all exposed individuals cannot be maintained within the studies, and sometimes there might be some loss to follow up, and also some loss to follow up due to the different competing interests, and due to for instance, if you are waiting for, let's say, for 1 year, some individuals or some exposed individuals might develop the outcome interest within 1 day or within a week or within a month of study. So in this case, these type of individuals are no more at risk of developing a certain disease. So in this case, we need to compute there is what called the percent use of observation as going to be taken as a denominator. So the percent use of observation is to mean that the number of times that an individual is at risk of developing certain outcome of interest. For instance, if our outcome of interest is, let's say, days, if you are following them and if your follow-up is set forth for let's say 10 years, and if an individual to get disease in let's say in the middle of the study after 5 years, then this individual is no more at risk of developing a disease. So we are not going to use this individual as a denominator for computing a risk. So in this case, this type of risk that we are going to compute that called incidence density, and we call it incident rate. So we can directly compute about the density. Where is the case denser? So here is the timing of the case. Is this in the earliest phase? Is this at the late stage? So that can be answered by computing what we call the incidence rate, which was computed by the number of new occurrences of outcome of interest divided by the total person years contributed by the individuals in that group of the cohort of individuals. So we can compute the cumulative incidence by computing simply using the whole individuals exposed at the very beginning can be taken as a denominator. But if you are dealing with the individuals based on the contribution of their contribution, which is the person years, so we can compute what called incidence density or incidence rate. So that can be computed based between those exposed and unexposed groups. So to compare between the two, this can be compared by the different ratio measures and also different types of absolute measures. So the ratio measures that the most common ratio measures that we can calculate for this cohort studies is about, we can compute the relative risk. That means a ratio of risk among exposed and non-exposed groups. That means the ratio of outcome among exposed and exposed, and that can be computed. And the other risk, the other absolute measure is about attributable risk. About we can measure about the risk difference. What's the difference in terms of absolute risk difference among those individuals who are exposed and unexposed, so that we can ascertain whether there is an excess risk or not. If there is an excess risk, so that excess risk can show us about the exposure variable is the risk factor for outcome interest or not. So this can be ascertained in such a way. So the
excuse me, Dr. Asres.
Okay.
We have 9 minutes. You need to wind up so that we can take questions and close the whole thing.
Okay,
So,
okay. So I can finish within 5 minutes. Okay. Thank you so much. Okay. So this risk can be computed by different computation techniques that you have seen. The rate of incident rate in exposed and the incident rate in unexposed can be computed. And based on the magnitude of this relative risk, so we can ascertain, for instance, if this ratio is going to be beyond 1, so that shows that this exposure variable under the state is a risk factor for outcome of interest, and if this is below 1, so this factor can be a protective factor for outcome of interest. So this is the way how to deal with the different types of effect measurement in the case of cohort studies. So as to the strength and limitation, so cohort studies are very much strong enough to determine the risk of exposure, because exposure has already determined before the disease selection. So we can ascertain directly about the risk of occurrence of outcome of interest. So with the cohort studies, we can also answer about several outcomes from a single exposure. So in the case of case control studies, we can ascertain several exposure for a single outcome. In the case of cohort studies, we can answer about a single exposure based on single exposure. We can ascertain different or multiple outcomes from that single exposure. The limitation, most limitation is very much expensive, so inefficient for rare disease and rare outcome. And at the same time, and the loss to follow up, particularly the attrition, if the attrition rate is very much high, so that can be not valid evidence. I think this analytical study, particularly for the experimental study, is going to be dealt with experimental study. I'm not going to deal with this analytical study designs. Particularly experimental study designs is going to have a fire station on clinical trials. So I'm not going to deal on that. And finally, I will have a very brief description on about the hierarchy of evidence. I think as to a hierarchy of evidence based on different evidence that we generate, these are the hierarchy of evidence. So the evidence that can be generated from the systematic reviews and meta-analysis can be a gold standard, and that can be taken as a very sound evidence. But this is the hierarchy of the evidence, that the strength of evidence that can be shown in the different study designs. So to evaluate epidemiological evidence, so with the different study designs, we have generated different types of evidence. So it can be the measure of frequency, it can be a description of distributions, and also the distribution of different types of association and different types of risk factors or determinants. So these need to be evaluated. So because the different evidence are prone to different types of errors, and that errors need to be checked whether that is a valid evidence or not. So we need to check about its internal validity, and so we need to check about its consistency or applicability or replicability of this evidence. So with this, with the internal validity, particularly the internal validity of the evidence can be threatened by these different main issues. And these three main issues are the bias, the confounding, and the chance. And the bias constitutes about the systematic error that can be interfered with the investigator. And the confounder is something external variable that can mask or that can confuse the association between exposure and that of outcome. And chance also another random error that can compute for that can play a role for explaining the association. So these are the main classification of errors that we encounter during the different study design. It can be systematic or it can be random error. So random error constitutes about the chance, and this systematic error constitute about the confounding, and different types of bias constituting selection and information bias. So we need to check into the different types of these different bias. We need to check into what are the different bias, what are source of bias, about selection bias, information bias. It's about bias that where there is a bias or there is a systematic error introduced during selection, systematic error introduced during information bias need to be controlled and need to be very checked during selection. So we need to check about the design stage, at the conduct analysis. We need to be very curious enough in minimizing the effect of bias in our studies. And the other thing is about confounding, particularly about effect of confounding, is about that is a third or external variable, whether that external variable is external variable that can confound or that can mask between. There is association with exposure and outcome, but that can be masked and that can be confused by another variable. This needs to be checked with the different techniques. So the different techniques that we whether this association with exposure and outcome can be explained by this variable or not can be checked by the different states at it can be at design or it can be at a different levels. So to define the confounding must be an independent risk factor for outcome of interest, and at the same time an independent risk factor for exposure of interest. They should be associated with exposure and outcome independently, but it shouldn't be at intermediate between exposure and outcome. So it shouldn't be effect modifier. Rather, it should be a third external variable that can be associated with that of exposure and outcome, but it shouldn't be an internal the modifier variable. So this can be controlled and prevented by using these different techniques at the different design stage. So we can randomize, so that if we are randomizing, we are randomly allocating both the known and non-confounding variables across both the different comparing groups. So we can also restrict some confounder variables. So individuals having a confounder variable can be restricted from being enrolled in the study. So this this way we can also control for the different types of restriction. And the other thing is we can also match. We can make it similar. Both the different comparative groups can be made similar with the different types of confounded variables, so that we can minimize the effect of these confounder variables. So these are the design stage. But if the control of if the confounding cannot be minimized and prevented at the design stage, so we can control it after during analysis. So we can control it whether the effect is free of confounding or not can be checked by using a stratified analysis, and also we can by using standardized rates, for instance, by standardization of different rates, particularly mortality and different types of rates. And the most common one is particularly dealing with the multivariate adjustment, and different regression models can be applied for adjustment. So after evaluating all this association, the next thing is about we are sure that the bias, our evidence is free from bias and our evidence is free from confounding or effect modifier. And then we need to examine for statistical significance whether this is due to chance or not. And that's what about the effect of chance. And the effect of chance can be computed by simply testing whether that is statistical, that association has happened due to chance or not. And this can be answered by what called statistical significance testing by using different types of hypotheses and based on the different cutoff points for p-value. And the most common p-value commonly used is 0.05, but with the strongest p-value even we can use it about the p-value of 0.01, so that we can use the p-value. The p-value indicates about the effect of this. If this association can happen due to chance, is very much minimal. The lower the p-value, so the lower the p-value, the lower the chance, the lower this association could be due to chance or not. This is the main implication of the p-value that can be used as a cutoff point. And even we can also use a confidence interval when the confidence interval contains the null value. So in that case, we can say that this has happened due to chance. And then, so in this case, we can this association cannot be free from chance. So after doing all this, the next thing is about if you are sure that our evidence is free from bias and our evidence is free from confounder or third variable, and then our evidence is free from chance. The next thing is, could this association be causal or not? So because association couldn't be causal, so we need to check into the different guidelines about whether this association is causal or not. So to do this, we do have different criteria. We call it what we call the Bradford-Hill criteria. So these criteria do have this about, sometimes we have 8 or 9 criteria, but these are the most common criteria to use to ascertain whether that association is causal or not. So based on the strength of association, whether the odds ratio relatively is very much strong or not, that is very much strong, very much far from null value of 1. And whether this is consistently replicable or not, and can this odds ratio relatively can be replicable in different settings. So that can also show us about the causal link and specific association and independent association, a temporal relationship, whether the exposure precedes the outcome of interest, and whether the dose response relationship, if you increase the dose of the exposure, then the response can also have a equitable response. So in that case, and if there is a biological plausibility and reversibility, that means if you reverse and if you remove the exposure status, so we need to show about the reduced effect of the reduced incidence of the outcome of interest. So in this case, these are the criteria that need to be filled to say that is a causal, because association doesn't mean that that's a causality. So the causality can be assessed based on these different criteria. So this is all what you have, and thank you very much for your attention and for your time, and we can entertain the different questions and suggestions. Thank you so much.
Thank you, Dr. Abyot Asres, for that very nice presentation. And I thank all the audience for their kind attention and their time. So, after listening to your energetic talk, I understand that epidemiology is one of the most happening topic in public health, and it portrays a data-driven systematic approach. And actually, after COVID, new things are happening, and so this epidemiological information will help us to plan and evaluate strategies to prevent the spread of infection. So today's insightful information that we gathered here has personally impacted me. No wonder epidemiology is the backbone of public health. Even in India, we have been making policies, planning health programs based on this field. And the studies that we have conducted have resulted in very fruitful programs. So, yes, it shall be a main source of knowledge for all the health professionals in the coming times as well. So, congratulations to you, Dr. Abyot Asres, for so assiduously preparing more than 140 slides to share with us. And I'm sure all of us feel enriched by what you have presented to us. Thank you. Thank you very much for this delightful learning that we have had in this session. And I would like to open the session now for question and answers, after which we will present a certificate of appreciation to Dr. Abyot Asres. Any questions, sir?
Participant, you are permitted to unmute yourself. You can unmute and put your question. Doctor, also there are some questions on the chat box.
Dr. Asres, there are questions on the chat box. You can just run through them. I think most of them have written nice lecture. Right? Are there any questions which we can take? Yes, sir. Any questions from anyone?
Yeah, Dr. Abbott, and just I wish to know, how do we control, what is the difference in between the controlling confounding factor and the bias? What are the ways to control bias and what are the ways to control confounding factor?
Dr. Asres? Dr. Asres?
Okay, so can you
Get
respond on? Can you respond on each question, or can you take note of the questions and then respond?
No. Please respond to each question.
Okay. Okay. Thank you very much. So the different, both these confounding and the bias are the variables or the different types of errors that can be encountered during different epidemiological assay designs. So for the bias can be systematic errors that can be employed during selection. It can be bias selection for case and control, for instance, differently selecting case and controls, and differently observing both case, exposed and exposed in the case of court series. So in this case, if there is a measurement bias and information bias, so this can be controlled by having a strict definition for case and controls and very strict definition for exposure, and also maintaining the better solutions or better mechanisms for retaining individuals so to minimize the loss to follow-up and attrition. So far we don't have there are some contemporary issues about controlling statistical mechanisms for controlling bias, but so far we don't have any mechanism for control. Once the bias is introduced, it's very difficult to control it. But in the case of confounding, so we can minimize that. We can also prevent from interpreting our evidence So by making use of different mechanisms, for instance, by restricting. For instance, if age, being an older age can be a confounder for certain parameters, so we can restrict our study only for younger people. This is what we by restriction. And then we can also match individuals. For instance, if you are dealing with a kid control and cohort studies, if you are, let's say, as these examples, if this the older individual can be confounder, so we can make the same proportion of older individual pose in the expose and export, and we can also ignore both the elder people both in the case control, so that we can match them. We can have the similar. We don't have any bias, and we don't have any differential mechanisms in the measurement and differential mechanisms in the case of measurement. So we can control confounding at the design stage. We can control the confounding at analysis stage. We can control for it. We can prevent and we can control. But so far for bias, so we need to prevent it. So once it interferes in our study, it's very difficult to control it. But there are some such advancement has been happening now to control for the effect of bias. So for the control of confounding at analysis stage, so we can stratify it. For instance, if the alcohol intake can be a confounder for, let's say, smoking is the lung cancer association. So we can stratify the smoking lung cancer association among those individuals who are alcoholic and non-alcoholic. So we can see the effect size measurement. If there is a difference in the effect size measurement, and if the effect size is very much similar across those alcoholics and non-alcoholics, so we can certain that there might be some confounder variable. So based on this effect size measurement, so we can certain whether there is a confounding effect. This is what we mean by stratification. And the other standardization is about standardizing. For instance, the most common standardization is if you are going to compare, let's say, mortality rates among some developed and non-developing countries. So if you are comparing the crude estimates, so the crude number of deaths among those developed and non-developed countries and developing countries, in that case, the developing countries might have seemingly to have a lower death rate. But if you adjust them for their age structure, that by making use of it, a direct or indirect age standardization, so we are controlling for the effect of age as a confounder. And the last one is this both stratification and the standardization can be used only we are controlling for one variable at a time. So we cannot control for more than one variable at a time using stratification and standardization. So to do this, we commonly use what's called multi-variable adjustment by using different regression models, be it a linear regression model or Bayes regression model. So we can fit the most common potential variables with that of the key exposure variables. So we can see whether there is an independent effect of exposure variable and the study has been seen or not. So we can say that that is independent predictor or not. So these are the ways with which we can also control for the effect of confounding. And there are also some propensity match scoring also one analysis for controlling for confounding effect. Thank you. These are the two of my response on the question. Thank you.
Any other questions, please? Any other questions, please? Almost all of valid statistical models need randomization assumption, while epidemiological study not randomized. How we compromise these two opposite ideas? This is a question from LMU Buccal.
Okay, thank you very much. Of course, almost most of the models require different stats analysis require random sampling. That was the assumption. So the assumption for running all these different models is dependent upon the assumption of randomness. So because in practice it's very difficult to ascertain about this randomness, but we can compromise it by making use of different design effects. There's what's called this design effect. It means that to comparing a sampling size or sample size required, for instance, if you are dealing with a cluster samplings and if you are dealing with a stratified sampling. So because the random sampling is the gold standard, so we can control for the sampling scheme or sampling technique. If you are dealing with a sample cluster sampling, we can increase our sample size. Or even if you are dealing with a very strict stratified sampling, so we can even minimize the smaller sample size as compared to that of the simple random sampling. So based on this assumption, by increasing or by decreasing sample size, so we can use the assumption of randomness can be assumed to be for cluster sampling, but can also be used for stratified sampling, and other systematic sampling can also be applied for this. But otherwise, but an ideal situation, the most, well, as you said clearly, so the randomization, the random sampling is one of the requirements for fitting different models and sub models.
Thank you. Thank you very much. I would now request.
Yeah, I think the other thing is about. Sorry, doctor. about precision of odds-ratio relative risk. So this precision, the precision in terms of odds-ratio and relative risk can be measured by computing a confidence interval. So if this confidence interval is very much narrow, so we can say that our estimate is very much precise. And if this confidence interval is very much wide, so that the width and the narrowness can be dependent upon the different magnitude. But if the width is very much narrow, so we can say that our measure is precise. The odds ratio is very much precise. If the width is very much wide, so we can say that that measure is imprecise. That's the way how to measure about how precise the odds ratio or relative risk is.
Thank you. I would
I think
request Dr. Meher Chand to please display the virtual certificate of appreciation to Dr. Abyot Mizan. Thank you very much, Dr. Mizan. We really appreciate that you found the time to be with us and take the questions and answers. A very informative session. Many, many congratulations. So here
thank you
we
so much.
present to you a certificate of appreciation for your contribution to this 5 days international virtual workshop on research methods in public health. Thank you. Thank you very much. All of you who have attended the session, and especially to Dr. Abbott Asres, who has very kindly given 2 hours of his busy schedule to be with us. Thank you. Thank you very much. Have a very good
Thank
night.
you. Thank you so much.